name is Dr. Nelson Murray. I'm the County Director Health Services Nyeri, and I want to appreciate this opportunity just to interact with Emergency Kenya. We, as a county, I want to say when it comes to issues of emergency and ambulance, health department is a big department. In the county health system, we actually consume about 5 to 40% of the county health budget. So a lot of our money, of course, goes to payment of healthcare workers. We also invest a lot in commodities. So there's a lot that happens in this department. So I want to say that there are many challenges. Challenges are cross-cutting. But along the way, then we learn how to prioritize and on areas that we need to focus on. As you realize, we were selected as one of the counties for universal health coverage pilot program by His Excellency the President, something that we've been implementing for the last 1 year. And part of it is when you think of that universality, then we want to ensure that all our citizens, they get affordable quality services and of course that accessibility. So in terms of the matter at hand, I always discuss with the team, but we've realized that issues emergency is actually a weakness for us. We've had, we remember back in 2013, there's a time counties procured ambulances, which were more or less supposed to be community ambulances. So these were ambulances that were procured just to ensure that when the community need to find one to the facility, then they will just reach out to the coordinators of this ambulance. Okay. Of course, the challenge with that is procuring the ambulance was just one step. There was challenges with ensuring that the ambulance is it up to standard? Was it an ambulance that had what was required of an ambulance? Did it have trained staff? Did it have the supplies that are required of an ambulance? Did we have a coordination system? So these are some of the things that, of course, you learn along the way. You improve as you move along. So initially when we started, it was a big issue for us. Just ensuring that these ambulances are well maintained, they are well coordinated, having a coordination system. And I'll tell you today, we've not managed to have that. It has not been adequately addressed. But of course, these are things that you learn day by day. Then, of course, the other bit is if you go to our health facilities, we have a lot of healthcare workers who either have not, having gone through the pre-service training, there was probably a small module of emergency medicine and basically courses like BLS and CLS. So over time, we have not had sufficient opportunities for these healthcare workers to actually either get refresher or more or less just be trained on some of these courses. So that has also brought a gap. And as you know, as part of the hospital care, those guys who are working in the hospital, they need to have some of these skills to a certain level. Also, in Nyeri, we have a very, because in units we are talking about primary healthcare, ensuring that we also strengthen the other levels, level 1, level 2, and level 3. So we've also seen a gap at that level. It would be good if we can also have a community health volunteers having some basic skills on first aid, ensuring that our drivers who drive ambulances, they are not just normal drivers, they actually train on some of these skills. So of course, that is also a gap for us. The final bit, of course, is just the coordination across the counties as a region. If you look at this at the macro level, you realize that we don't seem to have a coordination mechanism because the accidents and emergencies, they don't have boundaries. So we don't have some sort of a coordination mechanism such that in the event we have some situation in Nyeri or in the next county, how do we coordinate as a region? So I think that is something, given that we share a very busy highway. If you look at the highway starting all the way from Nyeri to Thika, it's a very busy highway. If you drive on this highway on a weekend, there are so many vehicles. So I think to me that coordination lacks. So my thinking is we can take advantage of the regional blocks like the CEREC, the Central Region Economic Block, and see can we drive this agenda through that because we have some commonalities when it comes to that. As I said, of course, challenges are many. The other bit, of course, is just having people. Like if you go to the hospitals, we also thinking in terms of training people now for a long course, either in critical care specialists, emergency. I'm told now there are courses for emergency medicine for clinical officers. So we made efforts to train them today to have one in the country for our hospital, but we need to have more. The more the merrier. Yeah, it's a game of numbers. If you can have probably 2 or 3 in the county referral hospital, and each of the hospital. I think the final thing is about issues of structures and systems, more or less ensuring that within our facilities, do we have some structures and systems? Do we have a team that are we looking at this from an individual perspective? That yes, if you go to PGH, you have one person who is doing emergency medicine, but is he working around that? Meaning that with when he's on leave, that things still happen. So that has also been a challenge. We are working on it. With this newfound partnership, what started is just ensuring that we are now training teams such that we have an emergency team at the hospital, and this emergency team can even do simulations. And emergency, of course, not just about accidents. Like the other day we are having with all this talk about the coronavirus. We were discussing, we need to simulate in the event we had a case in the county referral hospital. It would be interesting to see how the system reacts to that kind of situation. So I think, to me, those would be some of the priority issues that we see as challenges in the systems. I want to appreciate the partnership that you're having with the emergency care. Because so far we have had quite a number of engagements. Part of it is we've done training of our healthcare workers, especially in the hospitals. So I believe that however much you want to establish a system, it starts a lot with, especially in the healthcare system. Key important, you have to invest in the workforce. So there has been a lot of investment through this partnership in terms of training our healthcare workers on emergency medicine, and they like the way your training is so tailor-made and is done in hospital, so they're able to identify with the environment. I also appreciate that we also got support by getting some ECG machines, and I want to guarantee you that to date we've actually had almost the numbers that I'm getting in excess of 500 ECGs done since these machines were donated. So I want to assure you that moving forward, this is something that we want to continue. And more or less, I know this right now as we talk, there's a training that is happening in the county referral hospital. They are training about 17 officers from across the facilities. So I believe this is just the start of a long journey. For us, we just want to see that we commit to it. As I said, if you look at our strategic plan that we just developed the other day, this is a priority area for us. So we hope to have to progressively invest in it. There's a commitment even from the county executive committee member for health services that we are going to invest on issues of emergency medicine. It's important to work through a system, not individuals, because some of these things, and that's why I said in the past, I've noted that we had challenges when we started, that the clinical officer in the county referral hospital who is trained on emergency medicine, what would happen then if he goes for leave, then the ECG machine would not work, so we had a lot of challenges. But I think through the interaction and training of more officers, now we have had more people who are able to use the ECG machine. And I think to us that's really important. That's what I'm saying. I even told them yesterday, because we had a to open a training, that this is going to be a performance issue. As long as you're working in the hospital, just to ensure that you don't forget what you learned, we are going to put it in your performance appraisal. That you need to do a certain number of ECGs within your performance period. So I think for us, we've learned a lot of that. And of course, the other bit is we appreciated the fact that you engaged the county. So it is a high time then we also need to start working as a block. As I said, we need to start engaging as a block. See, we have some commonalities. So we need to engage as a block. And I think given that you initiated that forum, I know you initiated a forum for all the counties, but I would also request that if we can also initiate now for regions, because it's easier to engage a region like the Central Region Economic Block, because there are some issues they share in common. As I said, they share a common highway. So it's good for them to more or less sit down and look at how can we maximize, how can we leverage on the strengths of each other, how can we maximize on the collaboration, on this coordination between us and the experts. And of course, you bring the expertise that you bring into this arena is of course very important, because this is something even across board. As I told you, capacity is not as good as what it would be expected to be. And I'll tell you, 4 years ago, or even 3 years ago, no, let's say 4 years ago, when just maybe when the county started, we didn't know much about you, but I think you've done well in the last 2 years. And I like the fact that first you started by doing some baseline on issues of emergency in the counties. I think that was a very important. It's always good to learn where are we, and then we can then decide on where we want to be in the next 2 years or so. So I think for me, I would say that we that bit of coming to the counties and first of all establishing their problems, it was key. So I believe that the best thing would be that as we move forward, we need to ensure that you engage more, so that if at all there are any platforms, if like now there's a conversation about universal coverage, if there are consultative meetings, kindly come and for some of us who have engaged with you, we have learned what we need to do in terms of taking emergency medicine to the next level. But I think also it would be good that you don't necessarily have to even when we have forums. At times we have intergovernmental forums. At times we have EVT consultation forums. So it would be good that you come into that space so that people get to know about you, because that's the only way then we can be able to use your expertise, and of course in terms of instrument. Health cannot be done alone. We are actually seeking partnerships. We've noted this is a big sector, as I said. So we need to ensure that we reach out to other partners. And there's no point of me struggling with something that I don't, I would rather reach out to a partner who is able to support me. And that way then we can work together. At the end of the day, we're working for the Kenyans. So whatever we need to do together, I think that's what is most important. But kindly take a, don't stay in Nairobi. Come to the counties. This is where action is happening.
Emergency care has been tough for us. First of all, because of the numbers. Our biggest challenge is the numbers. We are not serving just Nyeri County. In the last 1 year or so, we've been having a lot of influx for the neighboring counties, which have been having a problem with their personnel issues. So we've been taking care of a large number of people. And apart from that, with the introduction of the UHC, being a UHC pilot hospital, our numbers have ballooned. So our first biggest challenge is the numbers. The numbers are too high. This has not been matched by the increase in personnel at the emergency departments. As we speak, we do not have a qualified doctor in the emergency departments to serve. We are relying on clinical officers, and the only people we are lucky to have there at the emergency department are people from the surgical department. The surgical department, we send in our surgical trainees to the casualty department to help with the surgical issues in the emergency department. But the rest are usually dealt with the clinical officers. That's number one. Number two, what we need is what we have been facing is the basic stuff like monitors. Like if we came into if we have more than one patient that needs monitoring, it's difficult to monitor them because we don't have enough monitors. The other thing is just the number of personnel. Even the clinical officer who takes care of the critical issues is only one person. He's the only one who has knowledge actually in taking care of critical patients. And his knowledge actually is also limited because he's doing other things in the casualty department. That means even the people who are there, even if we are to send people there, there is this knowledge gap about how to deal with an emergency coming, how to do a triage, how to do the basic things before the next level. Those are the few challenges actually we have. Otherwise, we have actually like a casualty theatre, which we cannot operationalize because of personnel issues. Okay? The casualty, of course, it's a NAV, and we could do a lot in the casualty theatre, but we are limited by personnel issue. We don't have enough people to actually like work in the casualty theatre. And actually, we just got from you. What did we get? We got an ECG machine from you. Yeah, in training of emergency care, that goes a long way actually to fill in a gap of knowledge, because that was the biggest thing that was lacking. Number one. Number two, the cost of training some people privately to do that we would not have afforded as a hospital. So at least that has mitigated that. We got people trained at no cost to us, which is quite good, which increases the number of people who are employed. The other thing is like the ECG machine. It's there, but there's only one person who can use it. There's only person who is able to use it. You see, an ECG machine is not the paper and the graph, it is the interpretation. Yeah. As a consultant myself, I can't interrupt an ECG. I'm not a physician. Yeah. I don't have the knowledge. I can operate the machine. So we don't have any people, meaning people can use it, people who can operate it and actually interpret. There are very few. As we talk now, is only one officer who is doing that in the outpatients. And the inpatients now need to bring to the physicians to look at the ECG. We must address two things urgently, according to me. The knowledge gap in casualty. I don't have to train doctors. If I can get like 2 or 3 other clinical officers in the emergency department trained, maybe for just the ECG and the basic monitoring will be very good. Secondly, if we can enhance the knowledge of the person already trained so that he can be actually a trainer, it can be very good. Like Eric, who's been doing it. If we could take him to a course and he becomes a trainer, an in-house trainer, it will do us very good, because we'll just be giving him one person or 2 people and we can save that. We know that we have been able to capture many things of the casualty just by him being present there and doing ECG. We've captured pulmonary embolisms, we have captured myocardial infarctions, we've captured big things which we were able to admit in our ICU because of him being there. But he's alone and he's a human being. And I wish to tell you that in the next few weeks, if I'm given extra doctors, actually I wanted to remove him there and take him to ICU. He's needed in ICU. He's needed in ICU. We have a gap in ICU. We need somebody like him here. See, if I remove him from there, I'll now leave the proper gap we are talking about. In fact, I've resisted so much in taking him to ICU. Yeah, he's a critical care guy. He's a critical care guy, and we need him in critical care. But you see our pool. I wish I had 3 of them. We will need you like to come in really in a forceful way in the critical care, even if it's for a short time. After such a training, you come in a big way to see how are we implementing it. When their knowledge is still hot, then even if now you fizzle out, you come out, we would have set out the whatever. Because in many places, the people who want to be trained usually get training by experience 50% for their own CVs, not to sell. Once I get my paper, I'm a critical care person, I know I can get a job somewhere else. I'll go and still keep working maybe where I'm working. Maybe I'm working in the maternity ward. Yeah. I will not even be interested. Even if there's this call, there's a mass casualty, can you come? I will not even come. But if you had this, immediately after training, come in with people and do that, even if it's for a week, see how things are running, make sure these people are running. Then that culture will now be there. It will be our critical care culture. And then we'll see a change.
Afternoon. Welcome to Nyeri PGH County Referral Hospital. My name is Eric Warwingi. I'm trained on emergency medicine and critical care. Posted here in the year 2019. As of 1st April, I trained in Kijabi. I'm the only one who is trained on emergency medicine in the hospital. So I've been running casualty versus ICU. There are quite a number of challenges, but this doesn't come along without motivations. I would rather start with the motivations because they keep me moving. It's that all majority of the patients that we attend here, they end up surviving possible deaths. That is one. Two, we're getting to a position whereby we are able to empower other health workers to do the same. That is saving life. Then we are also like helping the county to do a roadmap of quality health care within the county. Among the challenges that we have is inadequate of resources. That is one. We've been having issues with resources, and then capacity building has been not been good. You remember like the case of our late governor, Nakuru, whose life would have been saved if there were good capacity building. Besides that, our infrastructure has not been, does not meet the current situation in our generation. These are all the buildings that were put long time ago when population was not as it is today. So we need like to change our infrastructure. And then the county is doing a lot to get us to where we are supposed to be, but that one does not come easy. So bureaucracy to some extent in quotes is hampering our service provision in terms of resources. They take too long to come, but eventually they are delivered. But before they get to on the ground, they take time. The current casualty we have doesn't have enough equipment to start with. Equipment at the moment we only have one monitor, and then that is for the vitals. We only have one monitor. So whenever we get multiple patients, especially the casualties, it takes time before you get vital signs in good time. Workload is another challenge. We get overwhelmed at times. Besides that, the task force, we have enough nurses, but you can't say that they are enough. And then, being the only person trained on emergency medicine, it is tricky because when I'm away, things don't work the way I would want them to work. With the current training that is ongoing in our hospital, I'm very happy because now I'll not be the only person who has the basic knowledge of emergencies and trauma management. The nurses who are trained there, the clinicians, and the doctors who are attending the training, they will add a backup to me whenever I'm away and whenever I'm in, and I need more of specialized skills to be performed. Then I'll be in a better position to know that this one can be able to perform the same. Every other Wednesday in our hospital, there are CMEs, continuous medical education, and I've always slotted positions and opportunities to present topics that majorly concentrate on emergencies and trauma. Ever since I got posted here, I've been doing and endeavoring to do mentorship. Then, like continuous, besides the continuous medical education, is what we call on-job trainings, OJT. Like the ECG, I'm the only person who does ECGs in the hospital, but at the moment I've been able to mentor clinicians who are here on internship. At least I'm able to say that I comfortably have five who can be able to do ECGs, but they cannot be able to interpret, which to me it's an added advantage because if they can be able to do the ECG and then send me via WhatsApp, I can be able to interpret for them. So the patients don't have to wait for Eric to come to do the ECGs. Then I've been training like trauma. I've not been able to do the advanced because I don't have the resources. but I've been mentoring people on trauma life support and cardiac life support, not the advanced. This time around, I'm not doing the advanced, but the general cardiac life support and the trauma life support. And no one knows it all. So whenever I've been working with you and relating, getting in touch with you, I get more knowledge than I got before. At the moment, I'm able to learn and as well as refresh my skills. So having you here on board, it is a God-given opportunity to still sharpen the skills and acquire more knowledge. Basically, how I learned to know about you is through our organization for the emergency medicine and critical care clinical officers. But before then, I never knew about you. I've been attending your trainings and they are quite powerful. So now that you've trained more in our facility, people will get to know that there is an organization, there is a foundation that exists and they train people. So there will be diversity. Now, other people will get to know about you.
I'm Nicholas Matimu Kabulia, a clinical officer in Nyeri Sub-County Hospital in Nyeri County, working in the outpatient department. So it's the emergency or the casualty of the hospital. And in Nyeri Hospital, most of we are at the entry point of the emergencies that come to the hospital. So there are some challenges because when we are dealing with the emergencies, we need some of the gadgets, the equipments that could be urgent or could help us to solve or to cater for the emergencies, where than when we don't have the equipment. So in Nyeri, we are privileged to have a patient monitor in our outpatient or the casualty, and it helps us do our SpO2s as we serve the patients and take our blood pressures as we monitor the vital signs as we are serving the patient. We have the ECG in Nyeri, yes, but the training of the ECG hasn't been done to all the users. So with the training that we have gotten in this emergency training, it's going to help us now do the ECGs in the hospital than sending them to the county referral. So we are seeing we are going to be well versed in serving the emergencies or attending to the emergencies in our casualty.
And I'd like to thank this organization for the training they have brought, at least to enlighten us who usually meet these patients as our patient and enable us to be updated on ways we can take care of our patients who really need that urgent intervention so as to save their life. From this training, I can say that I've gained a lot in terms of managing the emergencies or the casualties whom I'm going to meet from today as days goes on. I'll be able to manage them peacefully, calmly, so as to save their lives.
I came for the emergency care training, which has really motivated me, and I have learned quite much on the way to go about the emergency patients, and it has actually helped us to identify some of the gaps and challenges that we come across while handling patients in our department. And some of the challenges that we go through, it's like now we've been taught how to go about management of DKA and HS, and we've seen and found it difficult to some extent because some of our patients we're supposed to send them for the potassium levels, which we're not actually able to do them currently. because of the challenges of our laboratory. Some of the reagents go in and out of stock, and this one gives us a challenge on how to go about the patient. And actually, we are planning to start afresh when we go back to our facility on how to manage our patient. And actually, we are planning to take our colleagues through the teaching and the learning that we've gone through. And that one will kick off immediately after the training. We are also planning to talk to our hospital director to make some of reagent that we need that will help the patient to do the potassium and other baseline investigations in the matters of the treatment of diabetes, to make it actually available, if not possible for every patient, at least for the diabetic patient. We have also learned how to do a CPR, and we find it a challenge because we don't have a stable coach for the patient. We are also looking forward to go and make a proposal on how we are going to restart it, and to actually have oxygen 24 hours available in our casualty department. We also want to encourage our trainers and the foundation to train more of our staffs pertaining this, because actually it is an eye-opener to most of the facilities, and it is really encouraging. That's why we are not getting late. That's why we are coming and sticking to the class, so that we can actually grasp every knowledge that is being given unto us. And we would like everything, the information that we've taken, to be impacted to our service delivery.
Has been very important to me, in that majorly we receive, in terms of emergency, we receive 3 categories of patient. Number 1, we have RTA patients. Number 2, we have organophosphate poisoning patient. This course has helped me because in all the 3 categories, you need to save life. At least you have to do all that is required in saving that life. And this course has equipped me with a lot of knowledge in terms of handling those cases. And I really appreciate emergency medicine in Kenya for equipping us with that knowledge. And we hope to improve the quality of our care in terms of emergency and impart the same knowledge to the rest of the staff in our facility.